October meeting of the Maternal Health Access and Birthing Patient Safety Task Force. It's an honor and a pleasure to have all of you here again. I'm going to keep my opening remarks brief because we have a lot of work to do and a lot of hard work that's been done in the last couple of months that we need to respond to. But I just want to thank everybody who has been so responsive to the call for both quantitative and qualitative research, data, databases, and has really helped us get to where we are today. I also want to thank all of the task force members that have been so responsive in connecting us to folks, in connecting us to resources, and just connecting us to the obstetric and neonatal landscape that's really helping inform this report. I do want to note as well that we are aware that the deadline in the maternal health law was for September for this report, and we are behind schedule. We are sharing that with our legislators, and we also want to be very transparent about that with the public, but the level of depth and research required to produce a report of this quality, or the quality that we would like, is going to take a few more months. So I do also want to state that up front. And that's all on my end. On behalf of the Department of Public Health, I'm Christina Alonso. I forgot to mention that at the beginning, and I will pass it over to my colleague, David Selt, who's been critical in getting us to where we are today. And thank you, David, and all of your team.
Thank you, Dr. Alonso. Good morning, everyone. Good morning, members of the task force and everyone tuning in online. Thank you for your continued engagement on this critically important work. I'm really excited to be able to share an update on the research on the task force report and to be able to discuss some preliminary findings with you today. I do want to acknowledge up top that we are holding this meeting and holding these discussions during a really pivotal time for maternal healthcare, not only in Massachusetts, but across the country. It's difficult to really discuss maternal health care today without mention of HR 1 or OB3, the federal law that passed this summer, which some estimates show could lead to nearly 12 million people across the country losing Medicaid coverage over the next decade, including estimates of up to 200,000 in Massachusetts. Medicaid is the single largest payer for pregnancy-related care in the United States, covering over 40% of births nationally. And changes to Medicaid eligibility and enrollment set forth in these federal law changes are expected to have significant impacts on the access and affordability for maternity care for patients across the country. So this task force has an important charge from the legislature to report on maternal health care access, capacity, and recent closures in Massachusetts. And we're grateful at the HBC to be partnering with you on all this work. We here in Massachusetts, we have taken important steps forward. And I was just yesterday at a great event celebrating the 1-year anniversary of omnibus maternal health care legislation that, among other things, established this task force, but also established licensure for certified professional midwives and payment parity for certified nurse midwives, and many other really important provisions of that law. And so we hope that our report will really build off of that incredible legislation and set the foundation for continued improvements and changes. So for today's agenda, as I mentioned, we're really going to be spending the bulk of our time walking through with you our preliminary findings from our research and the first 3 chapters of the Maternal Health Task Force report. And really just want this to be a robust discussion and conversation with all of you. This is why we're having this meeting for 2 full hours. So please speak up and provide your guidance, perspective, input, and feedback. And then we'll conclude the meeting with just a brief outline of what's remaining of our work and a proposed timeline for publishing the final report. So before we get to all of that, we do have to approve the minutes from our last meeting in June. And so because we're doing this virtually, I will have to call for a roll call and a call of the yeas or nays. And if you were absent last time, you can feel free to abstain. So first, can I have a motion to uh, approve the minutes?
So moved.
Is there any discussion or edits or changes that anyone would like to propose to the minutes? Um, Hearing none, can I get a second to the motion?
A second.
Thank you. And I'll just be calling everyone for a call of the yeas and nays. So I'll start with the co-chair, Dr. Alonso,
Yay.
Nashir Burrell,
Yay.
Amy Gagnon. Amy? Dr. Osipuku?
Yay.
Amy, did I get you?
Yeah.
Thank you. Dr. Price,
Yay.
Dr. Shields,
Yay.
Lee Simmons,
Yay.
and Dr. True.
Yay.
Great. Thank you so much. The minutes are approved. So before we dive into an update on the research so far, just a quick reminder on our legislative charge. You can see here our charge is to study the past service closures of inpatient units and the impacts of those changes, to just look at the demographic information of patient populations whose access was most affected by past closures. On the right-hand side, we're charged with studying the current availability of and access to maternal health services across regions and patient populations in the Commonwealth, also looking at the maternal health care workforce, and then finally issuing a report with our findings and policy recommendations. Next slide. So just as a reminder, I wanted to reintroduce all of you to the HPC's Office of Health Resource Planning, or what we're affectionately calling internally to our office, OHARP, which has been supporting the task force's analytic work. OHARP was established pursuant to the new legislation that was passed earlier this year to develop a state health resource plan and conduct focus assessments of the supply and distribution and capacity of different healthcare services in relation to patient need and community need, and to make recommendations around drivers of disparities, misalignment of that service capacity with patient need. And so the team that we have been assembling for this office has really been the engine behind the research work that will feed into the maternal health task force report meeting. I also just want to echo Dr. Alonso in terms of just stating that you guys have all been so incredibly helpful in providing insights and connecting with us with so many different experts and community leaders and resources, and that's just been so helpful. So, Dr. Alonso, I don't know if you had anything more to add before we start to dive into our going through the findings.
Dive in. I hope
Okay,
everyone's
great.
comfortable. What is coming is very, it's tremendous. And we do want to spend as much time discussing the results of what we found.
That sounds great. So I am now going to turn it over to Kara Vidal, who is our director of OHARP, and we'll begin walking through our findings for the first three chapters here. And as I turn it over to the research team and staff here, again, just want to reiterate this really is a conversation, and you'll see here, and Kara will say some of the questions that we hope to get your guidance and input on. But with that, let's dive in.
Great, thank you so much. Wonderful to be here with you all this morning. As David and Dr. Alonso said, we are going to be looking at some of the quantitative results from chapters 1, 2, and 3. So that's an overview of Massachusetts births and birthing people, Massachusetts maternity care supply and capacity, and we'll be talking specifically today about hospitals and workforce. We'll have additional information about birth centers and office-based access and supply in a future meeting. And then chapter 3, our examination of hospital maternity unit closures over the last decade. Next slide, please. But before we get into those quantitative results, I did just want to give this group a quick update on the qualitative work that is ongoing, because we think that that is going to be an extremely important complement to the quantitative work that we are doing. That work is underway, and again, another thanks to the task force members who helped connect us with individuals who would be willing to speak on their experience. So we are using an approach of semi-structured interviews to try to answer 3 key questions. First, what are the opportunities and challenges around providing maternity care, specifically in hospitals and birth centers? What have the impacts of closures of hospitals been on patients, certainly, but also on the hospitals themselves and on surrounding providers? And then we'll be soliciting ideas on policy recommendations to mitigate the negative impacts of closures and strengthen the system overall. You can see listed on this slide the different types of individuals and organizations that we are aiming to talk to. We have contracted with JSI to help us conduct this work. I can say that the interviews are already underway and they are expected to take at least another 6 to 8 weeks. So we won't have qualitative results today to share with you, but look forward to bringing that back in another few months. All right. And with that, we can dive into chapter 1. So today you'll be hearing from me. You'll also be hearing from Charlotte Burlingame and Alexa Pava, 2 excellent analysts on our team. But I do just want to say up top, this is the work of a larger, excellent team of economists and researchers and policy analysts, and it's just our privilege to get to be able to share their work with you today. All right, so starting in chapter 1, our overview of births and birthing people in Massachusetts. Here we are showing you the number of births and the birth rate per year. And I think very obvious from the graph on the left, you can see that births and the birth rate in Massachusetts have been declining over the last decade. In 2022, we had about 4,000 fewer births than we did in 2012. Our birth rate was about 48.2 births per 1,000 females, ages 15 to 44, and that was lower than the national rate of 56. Also worth noting on this slide that 99% of births to Massachusetts residents take place in a hospital, as opposed to, for example, a freestanding birth center at home in a doctor's office. Next slide, please. Here we're showing you some demographics of our birthing people. So in 2022, about 45% of births were to birthing people of color. That percentage has been increasing since 2012. And about 30% of births were to birthing people over age 35, and that has also been increasing since 2012. If we were to look by insurance type, that has been a sort of a flat rate from 2012 to 2022. About 60% of our births are to people enrolled in commercial insurance, about 35% to those enrolled in Medicaid. Next slide, please. Now, in conducting this work, our team looked at a variety of maternal and infant health measures, and we looked at the data in many different ways. We looked at how Massachusetts compares to the US. We looked at how our performance is trending over time. We looked at how outcomes vary by geography and by demographic groups. And we saw many trends. You're probably familiar with many of them. Most of this work comes from excellent data from the Department of Public Health. But for example, we see that prenatal care adequacy rates have been declining over time, while severe maternal morbidity and C-section rates have been increasing. And in just a few slides, Charlotte will tell you a little bit more about those rising C-section rates. Geographically, we see worse outcomes in the Metro Boston area for multiple measures, including SMM rates, preterm births, and prenatal care adequacy. But the most consistent, notable finding across these measures is the serious gap in outcomes experienced by Black non-Hispanic, Hispanic, and publicly insured individuals compared to white non-Hispanic and privately insured individuals. Even on measures where Massachusetts overall performs favorably compared to the US, and you can see that in green in the first panel here, we see these disparities. And I should say that we didn't put every measure on this slide. You can see we were already out of space, but we looked at infant mortality and maternal mortality as well. Those are two other measures where Massachusetts has better performance than the US overall, also areas with disparities for these groups. We also see that disparities do not appear to be shrinking. In fact, on some measures like prenatal care adequacy, C-section rates, and SMM, they appear to be growing over time. I know the people on this task force are probably well aware of these data. I know a lot is being done across the state to address these disparities, but we bring it up here because it is, of course, important context on our births and birthing people, and also because you'll see throughout the rest of the presentation that we are going to break down our data where we can by race, ethnicity, and insurance type, and this is the reason for that. And I'm now going to hand it over to Charlotte.
Thanks, Kara. Good morning, everyone. Before I begin, I'd just like to acknowledge my colleague, Dr. Sasha Albert, for her work on the sections I'm presenting today. Next slide, please. Researchers have estimated that the population C-section rate should be between 15 and 19%, but in Massachusetts and the country overall, rates are higher than recommended targets and rising. This slide shows the C-section rate for total and low-risk births for Massachusetts in the blue and the US overall in the orange. In 2020, the C-section rate in Massachusetts overtook the US average and continued to grow through 2024 to an overall rate of 34%. Next slide, please. As noted on the last slide and represented here by the pie on the left, a little over 1/3 of Massachusetts births are delivered via C-section. The pie on the right breaks out C-sections into various groups based on obstetric characteristics. About 40% of C-sections are repeat C-sections, and another 40% are low-risk pregnancies without a history of prior C-section delivery. Since most birthing people who have a C-section will have any future deliveries via C-section as well, this pie, in combination with the parallel trends we saw on the previous slide, suggests that low-risk births are sort of driving the overall C-section rate in the state. Next slide, please. There's also great variation in the likelihood of having a C-section by Massachusetts hospital. Here we show the excess probability of having a C-section at a hospital relative to the probability of at Mount Auburn, which is the hospital with the lowest C-section rate in the state. So for example, a patient is 14 percentage points more likely to have a C-section at Stewart Holy Family, which is the bar on the far left, compared to having one at Mount Auburn. These results control for patient characteristics, yet great variation persists, suggesting that patient characteristics can partially explain a hospital C-section rate, but that there are other drivers. Next slide, please. We posed a variety of hypotheses for why the C-section rate is rising and why there's so much variation between hospitals. We explored whether patients were older or more complex over time, whether subsequent C-sections were driving the rise, potential drivers of hospital variation, whether patient demand played a role, and hospital policies and practices. Given all of this, we find that the rising C-section rate seems to be attributed primarily to differences in hospital culture and practices surrounding low-risk births, with some influence from changing patient characteristics, like becoming older or higher risk. Next slide,
Charlotte.
please. Oh, go ahead, David.
Charlotte, I wonder if we might just pause here and open it up to the task force and wonder if any of you have any perspectives or insights on what we're seeing in terms of rising C-section rates, especially for low-risk pregnancies.
David, hi, this is Kristen Price. Oh, sorry, Sarah, go ahead. You raised your hand.
You can go first.
I was just going to say, I think this is going to be an even more important issue when DPH promulgates the regs around levels of maternal care. And again, I think part of that is because we have to get ahead of the messaging that if you are low risk, you definitely don't have to go to a level 4 hospital to deliver your baby. And if you do, you actually may be at higher risk for having a C-section. So I think this data is really important as part of that messaging.
Thank you. Dr. Shields?
Yeah, thanks. I appreciate this review, and I appreciate that the data you have is from 2024, so pretty recent. Um, uh, I guess I'm wondering, were you able to look at whether the same thing is happening nationally? I suspect it is, but I just wonder about that, and knowing that places like the California Maternal Care Quality Collaborative have done a lot of work in the last decade around addressing ways to lower the risk for C-sections in low-risk patients. So maybe that's jumping the gun a little bit, but just to sort of think about the other work that's been done on this. Thanks.
Great. Thank you.
This is Hong. I'm just curious, did we look at it also by hospital systems? Do you see different system as, they're having their patient within, moving them maybe around their system? Do you see differences in C-section rate there? My other question is this an area that we may delve into when we're having the qualitative study being done? Is this an area that you can ask, kind of like, do they actually hear patient demanding it more from the provider side, or is it a care that's recommended at their system or hospital?
Yeah, thank you for that question. We did not look by hospital system, but we did have the opportunity to look by hospital cohort, and didn't see any sort of large differences there even over time. But looking by hospital system is certainly something we could do.
All right. Thank you for those comments. We'll take those back. And Charlotte, you can keep going.
Great, thank you. Great. An important note sort of in this work is that the C-section rates vary dramatically by race ethnicity. In Massachusetts, Black non-Hispanic birthing people experience a higher C-section rate than all other groups. And as Kara mentioned, this is a disparity that has not only persisted, but has actually increased over time. So you see their rates on the left-hand side, and in contrast, the rate among the white non-Hispanic birthing patients has stabilized and actually decreased slightly in 2024. Next slide, please. So we explored questions surrounding this disparity as well. Our own analysis and the research literature find that even after controlling for hospital and patient level factors, Black birthing people still have a higher C-section rate than their white counterparts. We found that indicators for C-section like eclampsia or umbilical cord issues were less influential on the probability of having a C-section for Black birthing people, suggesting that Black patients are less likely to have a C-section when they might need one, but are potentially more likely to have them when they don't need them. And in Massachusetts, Black patients are not concentrated in high C-section rate hospitals, and they seem to have the same access to resources such as midwives. And this all suggests that this disparity is not driven by characteristics of hospitals either. We do note here that provider discretion is an important determinant of whether a patient has a C-section, and we note this as a potential area for further exploration. And with that, I'm going to turn it back to Kara.
Great, thank you, Charlotte. We have one more slide in this section. Of course, we could have spent an entire 2 hours on data on Massachusetts births and birthing patients, but we're going to end this chapter here. And I'll tell you that what we hoped to present to you on this slide was an overview of Massachusetts birthing patient preferences for provider type, site of care, care models. And as we were doing this research, we're not able to find a lot of publicly available information that was specific to Massachusetts. We found some research studies done in small cohorts in Massachusetts, certainly some national literature, We found one excellent survey done in California of their birthing patient preferences, but didn't find anything equivalent in Massachusetts. So as this group is thinking about potential policy recommendations into the future, if you think it's important to have information about Massachusetts specific preferences, we found that to be a gap. Based on what we did find, in terms of site of care, we found individuals frequently cite a hospital's overall reputation and quality as a key consideration in where they go for hospital-based care. We also found that the COVID pandemic led to an increased interest in community-based births. And here that means anything not in a hospital, so freestanding birth center, at home, et cetera. However, we also found that patients expressed some limitations in accessing community-based birth, whether due to insurance coverage, insurance network, or financial limitations. In terms of choice of provider, we saw that individuals cited the influence of friends or family, again, their insurance network, and referrals from existing providers or practices. Here we see some data from that California study I was mentioning. 54% of respondents, over half, expressed interest in a future midwife attended birth. Would be good to know if there's similar interest here in Massachusetts. And we also read several studies that looked at preferences for patient populations impacted by health inequities. And we found that in those studies, these populations may express specific preferences, for example, for racial concordance with their provider, for gender concordance with their provider, language concordance with their provider, and generally emphasize the importance of relatability and feeling respected by their provider. That is chapter 1. And David, I can pause for questions, or I can keep going right into chapter 2.
I have a question.
Yes.
Did you look into just me to understand the reimbursement practice around birth services? Did you look into sort of how reimbursement is affecting the decision to do C-section rates, for example?
We do have, thank you for your question. We do have some data that just sort of shows the reimbursement rates. We can compare the rates between each type of delivery. And there is some literature that suggests that that does play a role in sort of a provider's decision to do a C-section. But that study is not based in Massachusetts. But it is something that we're thinking about.
Yeah, because the C-section, the rise seems to be like uniform across the state. So I'm just wondering if the providers are actually thinking about getting more money from doing more C-sections. I have a second question. Taking you back to the distribution, did you also look into sort of like linking payer status to race ethnicity? I noted 5% of people were on Medicaid, but do you look at the distribution by race ethnicity in terms of how many Black people were Medicaid, how many Hispanics were Medicaid, and do you think that could play a role in sort of, the disparity? Because people on Medicaid have higher rates of these bad outcomes. So is there a link between sort of, is race driving it or is payer status driving this association?
Yeah, that's a great question. We didn't look at it. We considered it, but I think it's a reasonable thing to look at. I think that's a reasonable hypothesis, but we didn't look at it in this work.
Lee?
Just to build on that point around payer-related data, I did note the slide you had there referenced, I think, a total of 95%. So wondered what that additional 5% was. And then I don't know if there's any ability to look into type of Medicaid program granularity that people are in, especially given, impending Medicaid eligibility and changes. I think that will be really important to understand people who, potentially might not have coverage in the future and how that would affect birthing units and
Sure.
care access.
Mm-hmm. So in terms of the other 5%, there's a very small portion of patients who may have Medicare. that could be health safety net also. There could be some self-pay. So it's really a combination of other very small categories. And if you look by hospital, that can make up a very, very small share of any individual hospital's payer mix. We'll show you that in a little bit. Could we look by type of Medicaid program in the data we have? That I don't think we could when we're using hospital discharge data for an analysis. It might vary based on the source, but for most of what we did here, I don't think that we have that granularity. But happy to go back and double check on that. But agree that if we do, that could be a very valuable way to cut it.
Dr. Shields?
Yeah, thank you. I had a question going back to the very first couple of slides. I noticed that the birth data was actually only through 2022, whereas some of the C-section data is actually from 2024. And I wondered about that discrepancy and, where are we at with getting the updated birth data through 2024 about the general numbers that you presented at the beginning.
I believe that there is some data already available through 2023. We were trying to be very careful in pulling numbers from the same source. So in some cases where we want to compare to national, we're going to pull whatever the latest is that we have from the same source for both. So there is some data already available through 2023. I don't know that I've seen 2024, but Dr. Alonso may know better than I would in that case. So it depends on the measure, and it depends on what you want to compare to make sure you're looking at the same time period and using the same method. We could estimate births using our hospital discharge data because 99% of births take place there, and so that could bring us all the way up through most of 2024, if not all of 2024. But you'll see throughout the analysis, we stop somewhere in 22, 23, or 24 based on the data source and based on making sure we're doing as much of an apples to apples comparison as possible.
Hung?
I think I was just thinking about the Black resident slide where you guys did quite a bit of modeling to say it doesn't seem like it's the hospital characteristics that's affecting their rate. So I'm just curious, so when you were looking at it, when you were controlling for their risk factors, and did you look at comorbidities? Are there certain types of comorbidity that did jump out? Did that have any influence? So I'm just curious about that. Like, what's the explanation, right, for the Black resident? And I'm just curious, did you find anything in the almost like clinical profile of these patients that stood out to your team?
Yeah, that's a great question. We did look at, we sort of consulted the research literature to have an understanding of, what are some of the clinical conditions or comorbidities that would indicate for C-section or pose a higher risk. And we did find that Black birthing patients were slightly more likely to have eclampsia, preeclampsia, but we're generally, especially in those sort of broader obstetric groupings, not so different that would explain the difference in its entirety. And when we show we have done looks where we compare sort of the probability of a Black birthing patient having a C-section at the same hospital as a white patient. And we did control for things like, age, payer, some of these other indicators, and find that there is still quite a bit of variation. And, although we have some clinical information in the hospital discharge data, we cannot account for sort of all possible conditions.
Nashira?
Thanks. Yeah, I just appreciate this very much, you all. Thank you for your work. I just have a clarifying question. You said that Black patients don't have disparate access to CNMs, and I was wondering if that's about that there's not disparate access to hospitals that have nurse midwives, but I'm wondering if we have data about the providers that Black patients have, even in a hospital with CNMs.
Yeah, thank you. We looked at we looked at the number of births attended by CNMs within a hospital for Black, white, and sort of people of color generally, and noted that and found that Black patients actually were more likely or had a larger share of births attended by CNMs than their non-white or than their white counterparts. But it's certainly true that there may be other factors at play, and just because they are going to those hospitals doesn't necessarily mean that they have sort of the same access opportunities.
Thanks for clarifying.
I have another question about a clinical issue that it's a little bit controversial, but I wondered if your discharge data is able to look at the role of induction of labor versus spontaneously occurring labor, and how that might track with the C-section rate and the disparities and all that.
Yeah, induction is something that we tried to look at, recognizing that it does play a role in whether or not someone will have a C-section, but we are unfortunately not able to look at it in the data.
One more question. I know that there are just a few hospitals that actually serve Black patients in the States, what we call the high Black 7 hospitals. Did you find something unique about these hospitals in terms of what, sort of resources they have that sort of makes it challenging to serve Black patients? Because just a handful of hospitals actually have the bulk of Black patients.
Yeah, it's a good question, and we did look into it because, as you say, we note that I think over half of Black deliveries occur in 5 Massachusetts hospitals, and we noted that they were not concentrated in high C-section rate hospitals. We note that these hospitals aren't the hospitals that have high Black-white disparities. They don't seem to be the ones that have few, or I guess less like midwife resources. So it's something that we're still trying to untangle and something that we're still looking into.
Thank you all. Great questions.
Okay, great. So that lets us move into chapter 2 here, which is about Massachusetts maternity care supply and capacity. We're going to break this chapter into 2 sections. I will tell you a little bit about hospital supply, and then I'll hand it back to Charlotte to tell you a little bit about workforce. So on the next slide, you can see that as of, 2023, Massachusetts had 40 maternity hospitals with 971 staffed obstetric beds. About a third of those beds are in the Metro Boston region. Between 2013 and 2023, staffed beds decreased by about 62 beds, or 6%. Now, because of hospital unit closures, which Alexa will tell you about in a little bit, there were actually 95 beds that were closed as part of a closure. But because other hospitals had slight increases in their staffed beds during the same time period, on net, we only lost 62 beds, or 6%. That 6% decrease in staffed obstetric beds actually tracks very closely to the decline in births that we looked at a few slides back, as well as a decline in overall maternity bed days, or total maternity volume in hospitals during that time period. So as a result, if you want to do sort of a volume adjusted measure of supply, what we're doing here is number of staffed beds per 1,000 maternity bed days. And we found that number's actually been quite flat from 2013 to 2023. It's about 4.5 statewide beds per 1,000 bed days. And that is because we're losing beds and the birth rate is sort of declining at a proportional rate. That number's been relatively flat. Now, the CBO projects that birth rates, which have been declining nationally, will steady off. And if that is to happen in Massachusetts, and if we continue to lose maternity beds at the same rate, then we could have a capacity issue. But because that isn't what we saw over the last 10 years, we sort of have that steady rate of beds per 1,000 bed days. You can see some regional variation. That's what you see in the map on the left-hand side of this slide. Those are HPC regions that we're using here. And I would call your attention to the southeast corner of the state, where you can see a few contiguous regions Metro South, New Bedford, Fall River, Norwood, Attleboro, those regions in the Southeast Massachusetts, which are all below that statewide average of 4.5%. And actually, if we go right to the next slide, you'll want to keep your eye on those regions again. So here we're looking at maternity unit occupancy rates. This is a new measure that we've calculated here. It's analogous to a general hospital-wide occupancy rate that you might be familiar with, but we've done it here specifically for the maternity unit. And we found in 2023, across all hospitals, Massachusetts had about a 64% maternity occupancy rate. That is higher than the rate reported by Illinois, which was about 45%. That was one of the few states we could find with any data on maternity unit occupancy rates. It's lower than that 85% standard that you may think of for sort of a general at capacity general acute care hospital. Of course, you leave a little bit of space for longer than expected stays, surge capacity, discharge transitions, et cetera. So I would be very interested to know if that 85% standard is generally used for maternity unit occupancy rates, if there's some difference for the maternity unit as opposed to the general hospital. But that's what we see statewide. You can see, again, quite a bit of regional variation. And again, I would call your attention to that same southeast region of the state where we see a few contiguous regions all with much higher occupancy rate than that 64% statewide rate, suggesting some potential capacity pressures in those regions. I'm going to keep moving because we've got so much we want to show you. Next slide. Thank you so much. So here we're looking at drive times. The black dots on the map are maternity hospitals, and then you can see that we've got zip codes color-coded by drive time to the nearest maternity hospital. So we'll look at the next slide on comparing drive time to the nearest hospital with the actual hospital that a patient uses. And of course, there's some difference there, but here we're just looking at drive time to the nearest hospital. Average drive time to the nearest maternity hospital was about 17 minutes in 2024. That was an increase of 2 minutes from 2013. And about 91% of all Massachusetts zip codes are within a 30-minute drive time to the nearest maternity hospital. Now, two really important caveats here. One, not everyone drives, as we know. So the actual experience of travel time to getting care could be quite different for different individuals. We also know that when you drive will make a difference in your drive time. And so again, we're showing you a single snapshot estimate here. But if you drive at rush hour, you're going to have a different drive time than if you drive at 2 a.m. These are, I think, done at a Friday at noon in March. And so you could cut these at a different time and get a different result. But we think this is a sort of a reasonable neutral estimate. You can see the yellow and red pockets indicating zip codes that are farther from the nearest maternity hospital. Those are in the Berkshire region, the Pioneer Valley Franklin region, and a little bit on the Cape and Islands as well. Interestingly, though, those were not the regions that had the highest proportion of patients driving more than 30 minutes for care, reflecting actual care, not just the nearest. Those regions were Norwood, Attleboro, Upper North Shore, South Shore, and the Metro South regions. On the next slide, we wanted to look at drive times for different demographic groups, and we wanted in particular to see if any groups, particularly groups that we know experience maternal health disparities, live on average farther from the nearest maternity hospital or travel farther as measured by drive times to their actual maternity hospital. And the short answer to that question is no, we don't see that pattern. So if you look first at the blue bars, that is average drive time by group to the nearest maternity hospital. And we see that groups that experience maternal health disparities, and particularly Black, Hispanic, and the publicly insured patients, do not live a longer drive time on average than their white, non-Hispanic, and commercial counterparts. And if we look at the orange bars, that is actual drive time. So that's where people actually get care. And the orange bars are always taller than the blue bars because you can't go shorter than your nearest hospital, but you can go further. You can bypass your closest hospital and choose to seek care somewhere else. And so we again don't see that the patients experiencing disparities are traveling further to their actual site of care. If you look at the gap between the blue and orange bar, that you can sort of think of as how many additional minutes a group travels on average beyond their closest hospital. And we see that that gap is larger for non-Hispanic patients than it is for Hispanic patients, and larger for commercial patients than it is for Medicaid patients. So the non-Hispanic and commercial group is traveling on average a longer, additional minutes beyond what they would have to in a bigger way, which may suggest some influence of patient preference and ability to travel on these patterns. Next slide. Okay, so that's sort of what I like to think of as the supply basics. How many hospitals do we have? Where are they? Do they have capacity? How long would it take people to get to them? But that's not the only set of considerations that patients use when they are deciding where to get care. And I think it's not the only set of considerations that policymakers may want to take into account when they are assessing supply and capacity. So we've put a couple of additional variables together here. Levels of maternal care, which has already been mentioned. Quality performance, of course, we actually saw in that slide on birthing patient preferences that quality is a key factor that patients consider in making that choice. We also wanted to look at communities served. So are patients, is a hospital a particularly important access point for a community? And we'll talk about this, but we look specifically in terms of Black, non-Hispanic, Hispanic, and publicly insured patients. And then affordability, of course, being an important consideration as well. Not the only set of considerations, but these are the some key ones that we had data on that we wanted to share with you. I'm going to give you some very high level results on these measures, and then you'll see that Alexa has integrated them into her closure analysis in chapter 3. Okay, next slide. Okay, I won't get into levels of maternal care in detail because this group knows that work better than I do. But as you know, we don't yet have levels of maternal care, the framework fully implemented. What we've done as a proxy here is we're just showing the average obstetric risk score for hospital patients by hospital. We've color coded it by cohort. Perhaps not surprisingly, you see the AMCs in orange and the teaching hospitals in the light blue on the left, indicating that they serve patients with a higher average obstetric risk score. And this is a score that measures an individual patient's risk for SMM. Now, I didn't actually show you this slide, but when we looked at occupancy rates, we also looked at occupancy rates by AMC community hospital and teaching hospital cohorts. And the graph looks relatively similar, maybe not in the hospital name, but in terms of having AMC and teaching hospitals with higher occupancy rates than community hospitals generally. And I think it would be very important, and I know DPH has some plans to do this, once the levels of maternal care information is finalized, to go back and rerun some of these analyses with a level of maternal care filter so that we can see if there's difference in supply or capacity or access by level of maternal care. Next slide. Here's quality measures. I'll just say very quickly, Charlotte has already said that we have variation in our C-section rates and that as a state overall, results are rising. Here we're showing quality performance by hospital on 3 measures that have a target set by the Leapfrog group. For low-risk C-sections on the left, you can see only a quarter of Massachusetts hospitals are achieving that standard. More than half are actually in the some achievement, limited achievement buckets there. In contrast to that, almost all of Massachusetts maternity hospitals are achieving standards for episiotomy rates and early elective delivery rates. So quality obviously an important consideration. On the next slide, thank you so much. bear with me as I as I explain the equation that we worked with here to you. So we wanted to understand whether certain hospitals function as particularly important access points for those populations that experience maternal health outcomes. And so to do that, what we do is we take an individual maternity hospital and we draw a service area around that hospital, and that's based on the area where its patients are coming from principally. Then we wanted to compare the demographics of maternity patients in the service area to the demographics of maternity patients at the hospital. So in the example on the right here, which is made up, let's just call this our Black non-Hispanic index. This example is saying that in the hospital service area, 10% of maternity patients are Black non-Hispanic. But at the hospital itself, 15% of the patients are Black non-Hispanic. And if you do 15% divided by 10%, you get an index of 1.5. That tells us that this hospital is an important access point for Black non-Hispanic patients. Now, it doesn't tell us why. It doesn't tell us that a hospital is doing something right or if they had a low index wrong. It just tells us that this hospital is serving a higher share of patients of this group than in the service area generally. And on the next slide, you can see we're just showing you data for 3 hospitals. These are the 3 hospitals that in 2023 had an index above 1.0. So for us, indicating they're an important access point on all 3 of the indices that we calculated: a Black non-Hispanic index, a Hispanic index, and a public payer index. And so that suggests to us that if a hospital like BMC, Signature Brockton, or Cambridge Health Alliance were to close, that could be a particularly concerning interruption for groups that experience maternal health disparities. And so we suggest that this would be something valuable to look at prospectively as if a hospital is contemplating a closure. Next slide. I think I only have a few more here. Here's payer mix. So we did payer mix statewide on that second slide on the demographics of birthing people. So remember, statewide, it's about 60% commercial, 35% mass health. These numbers caught me off guard the first time I looked at them because I'm used to having a Medicare percentage in there, but there is not a very large Medicare percentage in the maternity space. So you can see significant variation in the share of a hospital's patients that are commercially insured versus mass health insured. And then, Lee, you asked about the other category. It is, as you can see, for most hospitals, a very small percentage. And in fact, there are 2 hospitals where it looks a little bit bigger. That's Cape Cod and South Shore, I believe. And we have reason to think that there might be a data issue going on there. We think that might be mostly Medicaid patients in there. Okay. One more slide with data in this section, and this is with great thanks to the Research and Cost Trends team at the Health Policy Commission. This is their work, and thanks to them for letting me present it. So this is looking at hospital maternity prices, and this slide is doing a lot of work. It's showing us 2 important things. One is commercial price variation, and one is the difference in a commercial price to a mass health price. Now, all of this work is done for low complexity vaginal deliveries. So we are looking at sort of an apples to apples. We're not, we sort of in the methodology address the fact that hospitals see different acuity levels of patients. So we're looking specifically at low complexity vaginal deliveries here. And to illustrate the point about commercial price variation, first, just look at the height of the bars. You can ignore the lines for a second here. You can see on the left, Mass General, the average commercial price for this low complexity vaginal delivery, almost $20,000. On the right-hand side, you see Berkshire Medical Center closer to $10,000. That has implications certainly for affordability for patients, depending on what sort of coverage they have, what sort of out-of-pocket responsibility they may have. And it also has impacts and considerations for sustainability. So obviously hospitals receiving very different amounts in payment for this care. The other thing that this slide is showing you is the difference in what a hospital receives for its average commercial payment compared to its mass health payment. And so first, let's look on the facility side. This result was surprising to me. If you want to just look at the facility portion of payment, that's the orange portion of the bar in commercial, compared to the blue line, the light blue line. And so the part that surprised me is that most hospitals, as of 2023, actually received more from Mass Health for the facility portion of an inpatient stay than they would have from a commercial payer. Now, that is not true on the professional side. All hospitals received more on the professional payment from commercial insurers than Mass Health. And so the result, if you want to look at total spending, now you're looking at the total height of the bars compared to the orange line, that's total in total. You can see that most hospitals still receive more from commercial payers than they do for Mass Health. And I will just say very quickly for the last slide that I have here, David already mentioned the important considerations on the next slide of recent federal legislation, the potential impacts to, or not the potential, the known impacts to Medicaid eligibility. And as David said, we think this is going to be really critical to watch. We know that many there's sort of a general understanding of maternity services as a loss leader, as less profitable. And so as hospital finances may be impacted, we would want to watch very closely to make sure maternity access is not decreased. The bright spot, of course, Governor Healy did sign a spending bill hoping to offset some of those impacts. And that is good news, but definitely an area to watch closely. And I can either pause for questions or hand it right over to Charlotte to talk workforce.
Let's just take a minute to pause on this section.
I have a question from earlier on in terms of people going to sort of the nearest hospital versus the actual hospital. Do you have a reason? Is there a reason why people are not going to the nearest hospital but actually driving further to other hospitals? What could be accounted for that?
Yeah, there are at least two reasons. I think the two principal reasons. One is if the nearest hospital can't provide the level of maternal care that you need, you would have to drive further. If you're a higher complexity patient and you need a level 3, level 4 level of maternal care, recognizing, of course, that that framework is not fully implemented. But if you know you're going to be referred to, for example, a tertiary center, that could explain some of that bypassing. And we think some of it is also preference. Some patients just may choose to use a hospital that could be closer to work, could be where they got more of their prenatal care, what have you. But certainly would welcome other potential explanations from the task force members.
This is Hong, and on the same thought about distance to hospital, and I think on your slide, other factors, have you looked at in terms of, because where your OB has privileges, that hospital kind of does determine where you go, because I think in terms of the patient pathway into the system is you choose an OB first. And I don't know to what extent do OBs have like 2 hospitals that you would let your patient, or I remember, I guess, a while back when I was giving birth, I was given one choice and I chose that OB. So therefore I just went wherever she wanted me to go. So to what extent is it is insurance driven, but it is a preference in your entry point, your OB or the midwife or the system. I'm just curious about how does that kind of influence kind of like that ultimately which hospital you would be delivering at?
Yeah, that's a great question. I imagine it does have some influence, not something we looked at here. And the database that we were mostly using is the hospital discharge database, which wouldn't necessarily have that prenatal relationship, but interesting potential use of some of the novel work our team has done linking the ABCD to the HDD to see if we could tease that out. But insurance network also, Hong, you also mentioned insurance network as a potential explanatory factor there too.
All right, we have a weighty final section to get to, so let's move on to workforce, then closures. Okay. Thanks. Sorry, Kara.
Sorry, David, can I ask one more
Yeah,
question?
yeah, of course,
Couldn't
please.
get my hand up quick enough. I wonder if there's been a thought about, um, or even if there's a way to capture immigration status, because we've heard a lot about from hospitals about folks not being able to receive prenatal care and then ending up in labor and with not having had that prenatal care, which of course impacts outcomes. And so I don't even know if there's a way to look at that. But again, given the climate right now, I would anticipate, unfortunately, that fear around receiving prenatal care
Yeah.
might have significant impacts.
Yeah, I think that's probably right. I would may want to talk with some of our other partners here on the task force about whether those data are available. I think, for the same reason you mentioned, that fear and climate, we probably don't have those variables, nor would we necessarily want them available to us for all sorts of reasons. But we should talk and see if anybody does have a way to look into that.
And maybe on that federal slide that you have there, it might just be worth noting that could be a contributing factor, even if we're not able to capture
Yeah.
it.
I think one of the issues that compounds that is that regardless of documentation status, your mass health eligibility changes when you're pregnant. And so you bump up into general mass health. So if we were to look at insurance status as a proxy for immigration status, it would be erased at the time of declaration of pregnancy. So I think that's going to be a tricky one to be able to examine because of the laws that protect people in Massachusetts. And that might be something to say in the report.
Could I just ask a process question? I feel like this is incredible work and it's very dense, and I'm going to need a lot more time to look at the slides that you just presented and sort of give some feedback. So I'm hoping that there'll be opportunities I know you'll share the slides, but also to, maybe have some kind of dialogue before the next meeting to sort of, after we've processed more, all of this information.
Absolutely. This is a preliminary conversation. We thought it was worthwhile to have Kara and the research team be able to kind of give you the full context and answer preliminary questions, but happy to set up some time offline and truly to all the task force members, you will have ample opportunity to weigh in and help us shape this work. So thank you. We welcome it. And it is quite dense. I agree. But you're doing a great job, Kara. Keep going.
Handing it right to Charlotte.
Thank you. In this section, we explore trends in employment, geographic distribution, and other characteristics of obstetrician gynecologists and certified nurse midwives. In Massachusetts, OB-GYNs play an important role in birth care, and the workforce here has remained pretty consistent from 2012 to 2023. Residency slots have grown slightly over the past few years, that we have a fairly stable OB-GYN workforce, but the distribution of them per capita varies substantially by county, as we show on this map. So this shows OB-GYNs inpatient care per 100,000 women ages 15 to 64. So we have some areas with a higher number, Franklin and Nantucket counties with lower. And I'll just note that sort of broadly and across the state, Massachusetts has a greater number of OB-GYNs per capita than the US overall using the same criteria. Next slide, please. Certified nurse midwives are another primary provider of birth care in Massachusetts. Research finds that increased use of midwifery care is associated with improved patient and newborn outcomes, and prior HPC research has found that higher rates of midwifery care in Massachusetts hospitals are associated with lower C-section rates and episiotomy rates, as well as lower costs. More CNMs are providing care in Massachusetts over time, both on a total and per capita basis. We had a little over 300 CNMs as of 2022. And although CNMs have had full scope of practice since 2012, payer and hospital policies and practice cultures may represent other barriers to their full autonomous practice. Next slide, please. Representation in care is important, and research indicates that it can benefit Black patients in terms of patient and newborn outcomes. To get a sense of how well these two workforces represent patients in Massachusetts, we show the distribution of birthing people, OB-GYNs, and CNMs by race ethnicity. As you can see, both the OB-GYN and the CNM workforces in Massachusetts are less diverse than the birthing patients here. Next slide, please. Changing gears a little bit from workforce trends to care provision. Here we show the share of births by prenatal provider type from 2019 to 2023. About 90% of births had an OB-GYN as the prenatal provider, and this is a trend that has remained remarkably consistent over time. Family physicians as prenatal providers, in contrast, represented less than 1.5% of births during this time, and that's indicated by that small, darker orange portion of these bars. Next slide, please. Massachusetts had a larger share of births attended by midwives compared to the US, about 19 and 13% respectively. But midwifery involvement in birth care varies considerably by Massachusetts hospital. Here we show the share of births attended by CNMs at Massachusetts hospitals. And the rate of midwife-attended births ranges from less than 1% to nearly 70%. And there are several hospitals that do not utilize midwives as birth attendants. Next slide, please. We note here some recent policy changes affecting the maternal health care workforce in Massachusetts. As David mentioned at the beginning, starting in spring 2024, Mass Health offered coverage of doula services as part of Chapter 186 of the Acts of 2024, which created this maternal health task force. It included a number of policies directed at supporting and expanding the maternal health care workforce, including Mass Health reimbursement at parity for OB-GYNs and CNMs, reimbursement and a licensure pathway for certified professional midwives, and updated regulations for freestanding birth centers. I can pause here for questions, or I can turn it right over to Alexa Pava to walk through our next section.
Go ahead, Alexa.
Great, thank you so much. Could you advance the slides, please? Next one. Great, thank you so much. So before I begin my presentation, I just want to acknowledge the immense contributions of my colleagues, Jessica Liu, Dan Stern, and Zach Bin. Thank you so much for your work on all of this. So in this section of the presentation, we'll examine Massachusetts' recent hospital maternity unit closures, including the characteristics of hospitals that close their maternity service, the access, quality, and care delivery impacts of such closures, and where patients receive maternity care after a closure. So to start, from 2014 to 2023, there were 9 hospital maternity unit closures. You can see them detailed in the map on this slide. Those closures resulted in a 95-bed reduction in staffed obstetric beds. Notably, each of these closures occurred in community high public payer hospitals. Next slide, please. So we wanted to assess closure hospitals' importance to their communities, so we compared the race, ethnicity, and insurance status of the closure hospital's maternity patients to that of all of the maternity patients in their service area, so the area geographically proximate to or surrounding the hospital. If I could direct your attention to the left side of the bar chart on the screen, you'll see that we're displaying values for our public insurance representativeness index. 8 out of the 9 closure hospitals had an index value greater than 1, which means they served a larger share of publicly insured maternity patients than the mix of patients in their PSA. To put it in plainer language, this means that prior to closure, these hospitals were important access points for publicly insured maternity patients. Our findings were a bit more mixed for the Black, non-Hispanic, and Hispanic representativeness indices, which you can see displayed in the center and the right of the bar chart on this slide. But we did see that closure hospitals that served a greater share of Black patients also tended to serve a greater share of Hispanic patients. Next slide, please. So in the next few slides, I'll walk through our analysis of the factors that were associated with Massachusetts hospital maternity unit closures. We assessed closure hospitals' performance on certain volume, occupancy, financial, and payer mix metrics in the 3 years prior to closure. And then we compared that to community and community high public payer hospitals that didn't close their maternity services. We're calling that the non-closure cohort, and you can see the list of the non-closure cohort hospitals on the right of this slide. Next slide, please. So like I said, we're comparing the closure hospitals to the non-closure hospitals. We looked at metrics like total and maternity volume, occupancy rate, margins, prices, revenue, and payer mix. I do want to note here, you can see that for most of the metrics on the slide, the denominator is 7 closures, even though I just told you that we had 9 closures. That's because we excluded Steward Norwood and Signature Brockton from this analysis. Those closures were due to a flood and a fire. And because they were, unplanned closures resulting from a disaster, we think that they might not display the same characteristics as our other planned closures. Next slide, please. So here I'm providing an overview of our results, starting with volume and occupancy factors. So in their essential service closure filings, I should say, as part of this work, we did review closure hospitals' essential service closure filings. And in that documentation, they cited low volume and declining birth rates as a driver of closure. In our analysis, we found that hospitals that closed maternity services had fewer total and maternity discharges than hospitals that did not close their service. Closure hospitals also had lower maternity unit occupancy rates. Turning to financial factors, hospitals cited numerous financial drivers of closure in their ESC filings. That included unprofitability of maternity services, a need for capital investment in their facility, and broader financial challenges. Our analysis found that hospitals that closed maternity services were generally lower priced, and they received less revenue per case mix adjusted discharge than our non-closure cohort. Interestingly, and perhaps somewhat surprisingly, we found that closure hospitals tended to have higher margins. We've talked internally about some potential reasons for this finding, but maybe I'll pause here and ask for any kind of task force member thoughts and feedback about why we're seeing this. Okay, hearing none, I will continue. So turning to payer mix, you'll remember that all 9 maternity unit closures occurred in community high public payer hospitals. And this aligns with our finding that most hospitals that closed their maternity service had a greater share of publicly insured maternity discharges than the non-closure cohort. Next slide, please. So I just talked about the association between low volume and maternity closures. Here we're showing Massachusetts hospitals with less than 500 annual maternity discharges. And since 2013, you can see in the second row, the bottom row of this table, 6 of the 8 low volume hospitals have closed their maternity service since 2013. Notably, there were fewer closures amongst hospitals with less than 250 discharges. Only 1 of the 4 closed, North Adams. This may be explained by the fact that Fairview and Martha's Vineyard have been designated as critical access hospitals and therefore receive more favorable reimbursement policies. Additionally, Martha's Vineyard and Nantucket are both members of the well-resourced MGB system. Next slide, please. So having looked at the factors associated with closure, we then turned to think about the impacts. We found that nationally, closures led to increased distance and travel time to care, but that closures may have a range of impacts on healthcare delivery and outcomes. For example, some studies found that closures led to reduced C-section risk. This was because patients were diverted to hospitals that had lower C-section rates overall. Other studies found that closures led to increased FMM and neonatal and perinatal mortality. Still other studies found that there was no impact on maternal or infant health outcomes. It's worth noting that many of the incomes that I'm showing here on the slide appear to be time limited. So in other words, the impact of the closure dissipated a few years after the closure occurred. And that may emphasize the importance of transition planning when we think about closures in Massachusetts. I also want to kind of caveat that these results are all based on national literature, and we might not see the same impacts in Massachusetts. For example, many of these studies focused on closures of more rural hospitals. Massachusetts is smaller and just doesn't have, the same rural pockets as other states in our nation. But we do get into specifics, Massachusetts specifics more on the next slide. So we know that maternity unit closures impact patients and communities in ways that aren't going to be captured in our quantitative data. Kara mentioned at the top of this presentation that we're doing some qualitative work to dig into other kind of impacts and effects of closures that we can't just see in our discharge data. So we'll have more to say here as that work progresses. But as part of that ongoing effort, we've reviewed testimony from Massachusetts residents about the impact of certain closures. Community members noted that following closure, they experienced greater barriers to accessing care. For example, in the wake of Falmouth's maternity unit closure, patients faced increased drive times to a maternity hospital. Healthcare workers also noted staffing challenges at hospitals that receive maternity patients and an increase in the number of patients that gave birth outside of the maternity unit. Next slide, please. So I'll take the next few slides to walk through our analysis of the impacts of Massachusetts hospital maternity unit closures. We started by evaluating certain access, quality, and care delivery metrics in the closure hospital's maternity service area pre-closure. Then we looked at how those metrics changed in the same geographic area following the closure. So this isn't at the hospital level, this is at the geographic, the MSA level, the area surrounding the hospital. We found that Massachusetts residents faced increased drive times to their nearest and to their actual maternity hospital following a closure. Our findings mirror those from the national literature and from Massachusetts community testimony. So following a maternity unit closure, travel times increase. And this might be particularly burdensome for patients without regular access to transportation, without paid time off, without childcare, et cetera. Thinking about our quality and care delivery metrics, we did not find quantitative evidence that closures had a systematic effect on 39-week induction rates, low-risk C-section rates, or SMM rates. So these findings, or really the kind of lack thereof, might have been due to the limitations of our analysis. I've said before, closure hospitals had relatively low volume. That meant that the closures we reviewed affected a relatively small number of patients. And because in this analysis, we're looking at average change in a broader geographic area, we'd expect the impact of that small number of patients affected by the closure to be somewhat small. That isn't to say, though, that maternity unit closures had no effect on quality and care delivery. And in order to further evaluate any such impacts, we're going to conduct qualitative interviews with community members about the effects of the Falmouth and Holyoke Medical Center closures. Next slide, please. This map shows the change in drive time to the closest maternity hospital from 2013 to 2024. You can see that drive times increased in the zip codes surrounding closure hospitals, which are denoted in the black dot on the map. 3 zip codes, which are colored in dark orange, saw drive times increase by more than 30 minutes. Next slide, please. This graph shows drive times to the nearest maternity hospital in the closure hospital's maternity service area. So the blue bars are showing average drive time pre-closure, and the orange bars are showing the average drive time post-closure. And you can see that in all of the areas that were served by closure hospitals, drive times increased after the closure occurred. But the size of this increase differed. So some closures resulted in a relatively small increase in drive time, while others, like North Adams, Harrington, Falmouth, and Leominster, had a greater impact. Next slide, please. And I'm now going to turn to our third major analysis for this section, which we're calling the displacement analysis. So when a hospital closes its maternity unit, patients who might have otherwise gone to that closure hospital are forced to seek care elsewhere. The hospitals that receive the closure hospital's patients, which we're calling recipient hospitals, might differ from the closure hospital in terms of their volume, their capacity, their quality, and the populations that they serve. We looked at market shares in the closure hospital's maternity service area pre and post closure in order to identify those recipient hospitals. And then we compared the characteristics of closure hospitals and their recipient hospitals. Next slide, please. I won't spend a lot of time here, but for reference, we've included the list of closure hospitals and their top recipient hospitals for you. Next slide, please. And here's a summary of our findings. So recipient hospitals almost always had more deliveries than closure hospitals. They also tended to have higher occupancy rates. I'll note that it appears that recipient hospitals had the capacity to absorb closure hospitals' patients because their occupancy rates were generally below 70%. Recipient hospitals had obstetric risk indices greater than the closed hospitals. And as you saw on the previous slide, some of the recipient hospitals were actually AMCs or teaching hospitals. We think that this is potentially an area for further investigation. So once the levels of maternity care have been implemented in Massachusetts, the impact of closures on risk-appropriate utilization of care should definitely be further assessed. Recipient hospitals had similar or lower rates of low-risk C-sections. Most recipient hospitals had similar or higher Black racial representativeness indices, but they had lower Hispanic representativeness indices and lower public insurance representativeness indices. Next slide, please. So now I'm going to walk you through an example of this analysis specifically for Holyoke Medical Center, which is one of our focal hospitals for our qualitative work. So after the closure at Holyoke Medical Center, you can see that Bay State gained 10 points in Holyoke's maternity service area, subsuming Holyoke's pre-closure share of 8%. And we think that this makes Bay State Holyoke's recipient hospital. Next slide, please. So here we're showing a comparison of Holyoke Medical Center and Bay State Medical Center. When we compare the two, we found that Bay State had higher volume, a higher maternity unit occupancy rate, higher OB risk index, lower rate of low-risk C-sections, a higher Black non-Hispanic representativeness index, and a lower Hispanic and public insurance representativeness index. Next slide, please. And we did the same thing for Falmouth, which is our other focal hospital for the qualitative work. Based on the market share changes displayed on this slide, we identified Cape Cod as Falmouth's recipient hospital. Next slide, please. And here you can see our comparison between Falmouth and Cape Cod. So compared to Falmouth, Cape Cod had higher volume, higher maternity unit occupancy rate, higher OB risk index, a lower rate of low-risk C-sections, a lower Black non-Hispanic representativeness index, and a similar public insurance representativeness index. You'll see here that we've excluded the Hispanic representativeness index from this slide. Falmouth has a relatively minor share of Hispanic folks in its surrounding community, and we were unable to calculate an index value for that hospital for that reason. That's all I have. Large amount of information. Maybe I'll turn it back to David to open the floor up for discussion.
Thank you, Alexa. And I will also note that we are showing you, I think, a selection of the slides and research here. And for each of the closures, there is a whole set of analyses that Alexa did the summary of. And so I think when we share a copy of this version with the task force members, we can be sure to include kind of the full range of analyses so you can look closure by closure and see all the set of analyses for each one of those. I think of the 9 closures, right, Alexa?
Yes, happy to do that.
I have a question. How did you decide to pick Holyoke and Falmouth for the qualitative interviews?
Sure. So we reviewed a range of different measures, including drive time to the nearest, to the actual hospital, patient demographics, et cetera. And based off of what we saw in those measures, we chose Falmouth and Holyoke because we found them to be particularly significant and impactful. We were also looking for closures that were relatively recent to reduce recall bias in our qualitative work. So because of that, we excluded, for example, the North Adams closure. So there were a number of different reasons why we chose them, but it really boiled down to choosing closures that had a significant impact on their service area.
Would just say also, we also excluded the Signature, Brockton, and Norwood closures because they were outside of the control of the hospital administrator. So once you sort of narrow things that were quite old, things that were outside of control, it was a smaller number of closures where we were saying, how many patients were impacted, what was the increase in drive time.
Thanks, Alexa. That was really good. My question is, am I understanding correctly that there was no real systemic effect of these closures on all of these different outcomes we'll be looking at? I believe that's sort of the summary of what you're saying, right? Or is that too simplistic?
So we did see an impact of on drive times, right? So there was an increase in drive times to the nearest and to the actual maternity hospital for patients. We did not see a systematic effect on SMM rates, 39-week induction rates, or low-risk C-section rates. But again, it's not entirely unexpected given the relatively small volume of patients that were affected by the closures that we studied. And just want to emphasize that we don't think that there's no effect of closure, right? We just didn't see that effect in our quantitative analysis. And we definitely want to dig into impact of closure with our qualitative work.
And to tag on, this is Hong. Alexa, great work, by the way. The full team, I'm so impressed with the analysis and the in-depth and the thoroughness. To follow up on the question about the systemic effect, how did you guys end up choosing those exact 3 outcomes versus, I think initially when we stepped into the initial overview, there were a couple more maternal outcomes you're looking at, and I'm just curious about how many did you look at initially, and then you decide to focus on those 3?
Yeah. So we did start with a lit review, like I presented about potential impacts of closure, and from there we were somewhat limited, I think, by data availability and ability to run the measures using our HDD data. So Kara or others on the call can correct me if I'm wrong, but it may be that those were the measures that we both observed as having an effect, and then that we observed that closures had an effect on in the national literature, and that we could also recreate using our own data.
Yes, and just that weren't too small. I think we showed some data on preterm births and low birth weight births, and that is such a small percentage of the population overall that I think there was just a small number impact, which wound up being the effect even for the measures that we thought we would be able to see an effect on. But those also got excluded because the frequency is just very low.
I think task force members are raising this, and Dr. Osabuco, thank you for raising this. I think we want to be really careful how we write this up and how we describe this in terms of how we're characterizing what we're saying here in terms of what our finding is and is not, and to be clear that this is about what we were able to observe in the data that we had and in the analysis that we did, and that's why you can hear Alexa emphasizing that this is not a finding that says there is no impact, this is what our analysis showed, but we are, marrying this with that qualitative work to try to really kind of flesh this out. So I hear you, and I think it's important that we are very clear and specific when we write this up and as we present this. So thank you for that. Dr. Shields, I saw you.
Yeah, it is really amazing work. I am curious about, you had a comment about the EMTs in Leominster noticing more ambulance births, and I wonder if there's any similar ability to get information about that around Holyoke and Falmouth, or any of the other closures. I would imagine that isn't hospital discharge data, but maybe there's some other source for that information, or maybe that's a target for some of the qualitative interviews.
Yeah, I think we've certainly imagined talking to healthcare workforce, local healthcare providers that were, in the communities affected by the Falmouth and the Holyoke Medical Center closures.
Including EMTs.
Yeah.
I'm not sure if this would be part of the qualitative piece or in an upcoming one of the upcoming chapters on community-based care, but I'm wondering for some of these closures where folks are receiving their, not just delivery, but pre and postnatal care and distances for that versus, where the birth actually takes place and if there's significant distances for that pre and postnatal care. And I'm also interested to see for some of the facilities that have seen closures, how workforce challenges have overlaid some of the volume and reimbursement pieces that you've shown here.
Yeah, so to the first question, I think to understand where patients are accessing prenatal or postpartum care, we would need to go outside the hospital discharge database, of course, and look at the APCD. My understanding is that it can be very challenging for us to pinpoint outpatient provider location in the APCD because oftentimes a claim is sort of billed under an umbrella group that might not reflect location. What we are going to try to do is use our registration of provider organization data through which our largest provider organizations report their physicians, including by specialty and sites of practice. And we are going to look, I think we're going to do 2017 to 2024, I believe, are the bookends of the analysis. And we're going to try to look and see if we see changes in locations, sites, whether tied to a hospital closure or not. And if we see any change, we don't have great FTE information in that data set, but might be able to try and just do head counts. So do we see changes in sites of care generally, and do we see changes in head counts of providers at that care as the best proxy? Because we agree it's very important, but it's harder to capture in our data sets. And then I would just say on the workforce challenges piece, that is, I believe Alexa can correct me if I'm wrong here, reflected in hospital essential service closure filings as a challenge. And if you have any thoughts on where we might be able to layer in some data on that, that's not something I think we felt we had good access to.
Yeah, I would imagine in the qualitative interviews, the facilities that have seen closures would have information on their vacancy rates for various professional types in their maternity services.
Yes, it is definitely a question in our qualitative interview guide.
And I think we might have MHA some vacancy rate data that we could share, but not for all professions type, if I'm remembering correctly. I think it would mostly be RN.
I see.
Maybe, and nurse midwives, but I don't think our physician vacancy data is broken down by specialty.
I see. Great. Be happy to review and see what we could add with that.
I'm just curious in the quantitative side for the closure and the recipient hospital, did you look at kind of what is the reimbursement rate for the births at the recipient hospital like after the closure to see because you're having more discharges come from different payer type, I would expect, did that either increase your average or did it decrease? Just curious.
We did not look into that, but I think that's something that we could definitely consider doing.
Yeah, we may have, I appreciate the line of thought there. We may have some challenges in timing of closure, in that there isn't as much post for some of the more recent closures, and how long you might expect after the closure. You would expect to see sort of the gain the market share, maybe increase the leverage, go sort of renegotiate the prices if that's the logic there. I don't know if we'll have quite enough post data, but it's interesting, and we'll definitely go back and discuss.
Maybe putting the notes, as you're writing up the report, as something that we should probably to monitor, right?
Mm-hmm.
And beyond looking at, even though it might be challenging to look at impact on the recipient hospital's reimbursement, we could perhaps integrate RPP and compare prices at, price levels of the whole hospital, but of the closure and the recipient hospital.
We could do that.
In terms of workforce distribution, I noticed that we are kind of privileged to have an abundance of OB-GYNs. Did we look specifically at like deaths of distribution of special like MFMs? Because the levels of maternal care actually depends heavily on distribution of MFMs. Did we look into that?
Charlotte, do you want to take that one, or we could come back? Because I know Sasha did do some looking at that, but I don't actually have those results on hand.
Yeah, I may direct that to Sasha Albert.
Yeah, thank you for the question. We did some exploration of how MFMs are used in the Commonwealth, knowing that some of the research literature suggests that a possible overuse of MFMs in some contexts. And we didn't see results that sort of indicated that was happening here, but we would need to do a little bit more digging into the data to be able to comment on sort of the overall statewide distribution of that workforce. So we'll take that back. Thank you.
Yeah, I have two comments. Again, thank you so much for this work. The first one is just going back to the OBGYN numbers per population. Worcester County has a lower number than some of the others, and just to remind you that even though you are saying family doctors only provide less than 1.5% of the births for prenatal providers at UMass, it's about 10 to 11% of the births for family docs. So there is some variation locally for that. So for whatever that's worth. And then forgive my ignorance on this, but I'm just wondering if there's potentially more, data sources address like birth certificate data somehow shows where the baby was born, certainly the name of the hospital, but I don't know what happens if there was an out of hospital birth, like if someone's born in the ambulance between Leominster and Worcester. But are there other ways to sort of complement or confirm your hospital discharge data if we had more up-to-date birth certificate data to look at that stuff in the 2023-2024 range?
There is definitely a wealth of information available through the birth certificate data. We did use some of that in our work. In terms of the out-of-hospital deliveries, I believe we actually have counts. DPH publishes counts of where the birth occurred by hospital, as well as at the Seven Sisters freestanding birth center. And then I believe there's an other catch-all for en route to the hospital, doctor's office, or home. So we can see those numbers. They're quite small. I think we had on that first slide, about 99% of all births to Massachusetts residents are in a hospital. So we could see those counts. Whether we could see a change over time with that small of a percentage and know that it was meaningful versus due to some natural variation, that would be harder, I think.
Lee?
Um, Kind of along the same lines on some of these workforce questions. I'm wondering if it's reflected um, when non-hospital based providers are um, or non-hospital employed providers are attending the birth. For example, with my very small N of one, I had a nurse midwife attended birth, and the hospital I gave birth at is not listed here. And I'm wondering if that's because they were um, I'm just trying to figure out how that would be reflected if it is for those that have privileges at these hospitals but aren't employed by them.
So I will say if you're looking at the share of births attended by CNMs by Massachusetts
Yeah.
Hospital, we do restrict that exhibit specifically to hospitals with 400 or more births in 2023. So some of those smaller hospitals um, wouldn't be included, or hospitals that had at least one birth attended by a midwife. But as far as I'm aware, it is not the data from DPH is not restricted to midwives that are employed by the hospital.
Okay. Again, with my N of one, I would think it would appear there, but that's an N of one.
Any other questions, comments at this point? I'm sure many of you will take some time to look at this again and digest, and we'll have some further future meetings to continue this conversation and discussion, of course, as we continue to move towards policy recommendations as well. But happy to entertain any further comments at this moment. Okay, seeing none. Kara, do you want to just tell us what our next steps are?
Sure, and we may have some slides to that effect. Oh, well, here were some discussion questions that I think you all addressed very well and didn't need any prompting. So if we want to go to the next slide. Great, thank you. So the couple of big things that our team is working on, first of all, we didn't talk at all about freestanding birth centers today. We are actively doing that work. We don't have as much data in that space as we do on hospital and some of our other workforce care. So that's going to be a lot of literature review. It's getting a lot of emphasis in our qualitative work as well. And we'll also talk a little bit, as I was mentioning, that analysis of outpatient locations of care using our registration of provider organizations data. So that work is underway. Of course, some revision and cleaning up response to comments and questions for the work you've seen. And then the qualitative work is also underway. I think it'll take at least another 6 to 8 weeks to get through all of our interviews or the bulk of them, but should be ready in about a month and a half, 2 months to come back and tell you what we've learned in that space.
So as I look ahead and think about the work we have left ahead of us, I do think coming back in probably that 2-month time period when we have the results from the qualitative work and some of the additional pieces of work that Kara just mentioned, meeting again to review that and have that further discussion with the task force seems like a great use of our time. I do think that there is probably another conversation around policy recommendations and how we want to start thinking about how we interpret all of this great research and turn it into forward looking. What do we want from our maternal healthcare system, and what do we want to put forward to the legislature, and then perhaps a final meeting to consider a final report and consider a release of a final report. So as I look forward, I probably see 2 to 3 more of these full task force meetings, taking us into early 2026. And I don't know, Dr. Alonso, if you have thoughts on that.
I really don't. I think we're all still digesting all of the presentation. I think too that we expect a similar presentation when the qualitative results come in. So just thinking about those of you that want to take some time to digest this and reach out to us, and we can meet to further deep dive into your reflections and responses to the data, I think would be really great. And then we will be in touch about scheduling the next meetings.
Yeah, that sounds great. I think Dr. Alonso and I both have a feeling that, certainly we want to move expeditiously here, but having a high quality report that is impactful is our number one priority. So any final comments or questions from the task force members before we close today's meeting? Glee?
I just have one question on the process for policy recommendations and how you see that that process unfolding. Will you recommend policy recommendations for us to react to, or what do you think that will look like?
I suspect it would probably be a combination of some solicitation from task force members of ideas and areas, as well as us generating some draft proposals for the task force members to react and respond to and to provide feedback on, and then to have a meeting and have a full discussion on them. All right. Well, thank you so much for your time and attention and really insightful comments and questions today. Thank you to Kara, Charlotte, and Alexa for a great presentation. Excellent job going through some very dense material, but explaining it very succinctly. And we will share all of this with you, and we will continue this important work. Thank you so much, and have a great rest of your day.